Hi guys, welcome back to the channel. So last class we have finished actually the principle of surgery in cancer or cancer treatment. Then we have started with resection of the mandible, a part of surgery. So resection of the mandible is mainly two type: continuity resection and peripheral resection. We have started with continuity resection and will be continuing that today. Okay, let's start. Okay. Dissection of the mandible. When carcinoma shows radiographic or scan evidence of bony invasion, the lesion becomes a T4 lesion and a continuity resection is required. When the lesion is clinically adherent to the periosteum, it is assumed to extend into the mandible through small foramina, which also requires continuity resection. Okay. Now, if a tumor that approaches the cortex but is clinically separated from it, the removal of cortex as an anatomical barrier is valid. अगर कोई ट्यूमर कॉर्टेक्स को अप्रोच कर रहा है लेकिन वो सेपरेटेड है क्लिनिकली, it is approaching the cortex but it is clinically separated from it, so what we have to do, we should remove the cortex also, because as an anatomical barrier. Now, peripheral resection of the mandible are indicated in gingival carcinomas and less commonly in localized alveolar ridge carcinoma. Mainly peripheral resection we do in gingival carcinoma. Such peripheral resection have been the source of pathologic fractures if the inferior border is thin too much. अगर inferior border बहुत thin है तो it will result in pathological fracture. Most pathologic fractures in this situation occur at the junction of a resection's rectangular form, which means that there is one horizontal and one vertical border and the loading force is on the horizontal one. So in this situation, when the resection is in form of the rectangle, so in this situation the chances of pathological fracture becomes more. Okay, the chances of pathological fractures will be more. Therefore, when a peripheral resection is considered, at least 10 mm of inferior border should remain. कम से कम नहीं तो हम लोग को 10 mm of inferior border छोड़ना ही चाहिए, नहीं तो we should go for continuity resection. The resection should not reflect the soft tissue from the inferior border intended to be retained. The design of the resection should create a sloping walls rather than 90-degree right angle. So that was I was talking about. It should not be at 90 degree. 90 degree पे होगा तो क्या होगा, जो लोडिंग फोर्स होगा वो एकदम परपेंडिकुलर होगा. अगर ये 90 डिग्री पे हम रिसेक्शन किए, दिस इज़ 90 डिग्री, सो तो लोडिंग फोर्स परपेंडिकुलर रहेगा तो चांसेस ऑफ पैथोलॉजिकल फ्रैक्चर ज़्यादा होगा. हम क्या कर सकते हैं, ये जो एंगल है उसको स्लोपिंग कर सकते हैं, सो द चांसेस ऑफ पैथोलॉजिकल फ्रैक्चर विल डिक्रीज. ये यही बोल रहा है कि द डिज़ाइन ऑफ द रिसेक्शन शुड क्रिएट अ स्लोपिंग वॉल्स rather than 90-degree right angle. When a portion of mandible is resected with a continuity resection, the bony edges should be rounded and some form of stabilization, for example internal titanium stabilization, is provided to prevent displacement. और जब कंटिन्यूटी रिसेक्शन करते हैं तो हम लोग क्या करते हैं, बोन के एजेस को राउंड कर देते हैं एंड फॉर स्टेबलाइजेशन वी गिव इंटरनल टाइटेनियम. ओके, ताकि डिस्प्लेसमेंट ना हो, डिस्प्लेसमेंट अवॉइड करना हमको. नाउ डिसेक्शन ऑफ द मैंडिबल इन द एरिया ऑफ द रेमस इंक्लूड कॉन्डाइलर एक्सटर्पेशन, vertical subcondylar osteotomies of the ramus which preserve the condyle and the posterior border of the ramus are preferred. ऐसा बोलते हैं जो वर्टिकल सबकॉन्डाइलर ऑस्टेक्टोमीज होता है दे आर प्रेफर्ड मोर. Okay, we'll be dealing this in next class or continuing this in the next class. Till then, like, share, subscribe, and comment. Bye.